Award. Now it's a pleasure for me to introduce Dr. Maria Luisa. Dr. Maria Luisa is from Brazil, and she works in UAE since 3 years. Before that, she worked in many farms in Brazil doing embryo transfer, and she went to China as well, worked there doing embryo transfer. Then she had the opportunity to come to UAE, Najman, and she works in the MEK Arabian farm, whatever, you know what I mean. And then she works there since 3 years with embryo transfer and freezing and all the things. And she recently gave this talk, a very successful talk in Saudi. And now because of that, I invited her to come here to talk with you, and so that it is my honor and my pleasure to have my partner and my wife here to give a talk to you. Please, Malu, all yours.
All right. First of all, thank you for introducing me so kindly. And also thank you to JSG Qatar and again to you for the invitation. So, good night, everybody. And we will be talking today a little bit about recipient synchronization in embryo transfer program. This is new, so eventually we'll have some issues, but everything will be fine. So, what are the most common factors affecting the the pregnancy rate in the embryo transfer program? We have the embryo quality and embryo age, the operator's skills, the donor age, and for the last but not the least, the recipients itself. And acquisition of a good quality recipients still remains one of the most important components for the outcome of the pregnancy. And the best advice that we can give to the owner and the receiver from a colleague is to be very careful in the moment that we are selecting these recipients to use in our embryo transfer. And what we should know about these mares: their age. We have to evaluate their body condition, if they have some anatomic or reproductive abnormalities, and also we must know how to synchronize them with the donor. Because one of the major influences in the pregnancy rates of the recipients are the synchronization between the donor and the recipient. So let's start talking about the cyclic recipients. Here we have some data published by different authors performing different number of embryo transfer and achieving 65.4 of a pregnancy rate in the recipients until 82%. All of these results in cyclic recipients. And based in several papers, they said that we have a relatively big window to work with these cyclic recipients, and we can use them having ovulation since 1 day before the donor until 5 days later of this donor mare. And what this means? This is the donor timeline. Usually the insemination with fresh semen is performed in the day before the ovulation. Day 0, the day of the ovulation, and the flush usually on day 8. And if we use this as a guide, our recipient can have ovulation during all this period, and this will give it to us a recipient between day 3 and 9 on the day of the embryo flush. So here we have in this study, they transferred the embryos to recipients between day 5 to 9. And the best results were achieved using recipients between day 6 and 7. The pregnancy losses on day 5 and 6 were around 7 and 8, increased a little bit between day the lower embryonic death was on day 5 and 6. On day 7 and 8 increased a little bit, and on day 9 was the highest embryonic death, near 30. In this other one, they used the recipients between 4 and 7, with the best results on day 5 and 6, around 65 to 77%. When we are talking about the degree of asynchrony between the donor and the recipient, in other words, this is the difference between the ovulation between the donor and the recipient. So in this study here, the best results were achieving recipients that had ovulation 1 day or in the same day of the donor mare, and even 4 days later, with the pregnancies more than 70%. In this other one, the best results were always using recipients on the same day of the donor mare, with the ovulation in the same day, or 2 days after. None, in this one, they didn't try any positive asynchrony with the mare. And how can we do to manage this synchronization with the donor? We can induce the ovulation of the recipients using GnRH analog or HCG. And here I will show to you the comparison between HCG and the Zoreline during the breeding season. So the HCG, the average interval of ovulation was 2 days, and 88% of the mares having ovulation. When using the Zoreline, the average is quite similar, around 2 days as well, and 90% of the mares having ovulation. In this other one, again, HCG and the Zoreline, only three mares had ovulation failure, only 3%, sorry. So this means that 97% of the mares having ovulation using HCG. And when using the Zoreline, around 4% having ovulation failure. So almost 96% of the mares responding to the induction of ovulation. However, when we talk about the transitional phase, and why this is important, because it's the time that we are working here in the Middle East. We work autumn, winter, and spring transitional. The behavior of these two hormones are not the same. So here in this study, they split the transitional phase in two. Phase 1 is the early transitional, and phase 2 is the late, that is spring going to the summer. And when they use GnRH, only 20% of the mares responded to ovulation in the phase 1, and around 57% responded to ovulation on the phase 2. And when using HCG, 82% of the mares responded in the phase 1, and all of them having ovulation on the phase 2. Here is just the average of these two. So GnRH during transitional phase, around 38% of ovulations, and HCG, almost 91% of ovulations. Again, during the transitional phase and the breeding season, in this one, using a single dose of Zoreline. During the breeding season, cyclic phase, 88% of ovulatory response. And during the transitional, 61%. And this is important to us because here, eventually, we will face ovulation failures in the recipients, and we must be aware to know how to manage these situations if we face them. So what we want to see, what kind of characteristics we want to see in these cyclic recipients? A uterus without edema, of course without fluid, and with a very nice tonus, a progesteronic tonus. Why? Because one of the most important factors in selecting recipients is the uterine tonus prior to the embryo transfer. So a very good uterus, and also a presence of an active cell, very bright, with a nice shape. Here we have a video, let's see, okay, to play. Just is the same of the picture. We can see the cell here, very bright. Nowadays with the Doppler, it's quite interesting because we can see the blood flow around the cell. Here in this one, and in this other one. I started with without. Then I will turn the Doppler. We can also see the blood flow around this one, but we can see that it's less than this, because this cell here, it's older than the first one. And then eventually we will face these structures, hemorrhagic structures, but this does not mean that they are not active and that they are not producing progesterone that can keep this mare pregnant. And why the blood flow is an interesting tool? Because I have a high correlation with the progesterone levels, as published here by Dr. Ginter. Here is two different mares. In this first one is day 1, these two here, we can see a very low blood flow, and the progesterone levels around 1.5. Here on day 8, a very nice blood flow around the cell. The progesterone levels on this one around 14, and here around 12. And here on day 16, the blood flow already decreasing, sorry. The progesterone levels here it's around 5 and 7. And here it's on day 18, almost no blood flow, and the progesterone levels are less than 1. And what can we do to help a better quality recipient when we face these situations? Well, it's shown and proved by several papers that we can use high doses of oxytocin to prolong the diestrus, because it keeps the cell active. This situation here is more used for mares that are going to competitions and the owner don't want these mares coming in heat during this period, but we can eventually use it for some situations when we are using mares in diestrus around, let's say, day 9 or 10. I know it doesn't happen quite often, but eventually we will face this situation that the only option that you have to transfer an embryo is a recipient on day 10. With me, already happened this season, and here in this study, they give a high dose of oxytocin to the mares 1 time per day between day 8 and 10, 8 and 12, and 8 to 14. Of course, we will not transfer an embryo for a recipient mare on day 14. So let's focus in this one. So the control group that received salina, none of them had prolonged estrus. And when they used the 1 dose between day 8 and 10, 3 of 7 had prolonged diestrus. And here the prolonged diestrus were until 30 days when they stopped the experiment. They measure the progesterone levels. So these, the black dots, are the mares that had the normal cyclicity. So around the day 16, the progesterone levels are lower, and around the day 20, around the basal levels. And these other one are the mares that faced the prolonged diestrus, and we can see that the progesterone levels remains high until 30 days, more than 4 nanograms per ml. They also tease these mares, and they see that they behaviorally remains in diestrus. So no showing signs of estrus. They use the ultrasound also to evaluate these mares. The cell word is still there, still active, no signs of edema. And why the oxytocin helps to prolong the diestrus is because it decreases the secretion of endometrial cyclooxygenase 2 that plays an important role in the release of the prostaglandin cascade. We can also use some anti-inflammatories because some difficult transfer may lead a inflammatory reaction that can be detrimental for the embryo. Also, eventually during the procedure, we can grasp the uterus or cause some degree of abrasion that can release some prostaglandin. And of course, when we are more inexperienced, we can also have a difficulty to going through the cervix, and this can also cause some kind of inflammation. Here in this paper, they didn't transfer any embryo. They are just evaluated the progesterone levels of the mares and the PGF-M, that is the metabolite of the prostaglandin, measure in the blood. And they give the treatment for the mares with flunixin megumine between day 14 and 16, that is when the spontaneous luteolysis occurs in mares. So here, regarding the PGF, the control group had higher levels of PGF when compared with the treated group. And the progesterone levels of the control group were lower than the treated group. They also evaluated the blood flow around the cell. As I mentioned, they have a very nice correlation with the progesterone levels. Oh my gosh. And then here we can see the black dots are the control. So around the day 15, already a decrease in the blood flow of the cell. And in the treated group, we can see also a little bit of decrease, but much less when compared with the control. Here in this other study, they transferred the embryos to these mares, and they treated them with meclofenamic acid, flunixin megumine, or salina. And they did the treatment 1 day before until 4 days after the embryo transfer. And they measured the occurrence of the luteolysis that is inferred by the levels of progesterone when they are lower than 1 nanogram. So in the control group, 3 of the mares faced the luteolysis after the embryo transfer procedure. 2 of them on day 2 and 1 of them on day 3, sorry. And none of the 9 mares treated faced the luteolysis in none of the days. They also measured the PGF-M in this study, and what they shown here, day 0 is the day of the time 0 is the moment of the embryo transfer, and all of the mares, including the treated groups, had increased in the release of the PGF after the embryo transfer. Here, the dark dots are the control group, so we can see on the time 0 above 40, less than 40, and then we can see a slight increase. In the meclofenamic acid, it's here the white dots, so less than 20, and we can see an increase here with less than 1 hour after the embryo transfer, I increased. And in the flunixin treated group is the square here, again less than 20, and then we can see a higher increase, and around the 1 hour it starts to decrease a little bit. So all of the mares faced some increase in the release of prostaglandin after the embryo transfer procedure. We can also give you progesterone. It's indicated in some cases, and also now during the transitional phase because the hormones levels are lower. Here in this paper, they have a lot of groups, but we will focus in the control group that are cyclic mares that didn't receive any kind of treatment, and in the group 2 that were cyclic mares that received a shot of prostaglandin longer action 4 days before the embryo transfer. And in the control, they achieved 60% of pregnancy rate, and in the treated group, 76%. With the embryonic losses around the 6% in the treated group, and practically the double in the control group. In this other paper, however, they had two groups. They selected the untreated mares that were recipients that were classified as acceptable mares to receive an embryo, so they were very good to receive it in the day of the embryo transfer, and they achieved 78% with 14 days and 69% of pregnancy rate with 40 days. And the selected treated mares that were recipients that were, their characteristics were not very good to receive an embryo, so they give a shot of a short progesterone, short-acting progesterone, and the results were 75 on the treatment were given on the day of the embryo transfer. So they did the embryo transfer procedure and give a shot of short-acting progesterone. So the dose was, the pregnancy rate, almost 76% with 14 days, and 66% in 40 days. And the pregnancy losses, practically the same. We can also use HCG, not only for induction of ovulation, but also trying to improve the luteinization of the cells. In this study, on the day of the embryo transfer, they give 4 different treatments. They split in 4 groups, the mares. And on the day of the diagnosis, the pregnancy diagnosis, they measure the progesterone levels of these mares. So the control that they receive on the salina, the progesterone levels were around 8. And in the group treated with HCG on the day of the embryo transfer, it was around 11. They also looked into the pregnancy rates of these mares. So the control group had on day 13, 66% of pregnancies, and on day 16, 55% of pregnancy. And in the HCG treated group, 87% of pregnancy on day 13, and 81% on day 16. In the same study, they conducted another experiment. In this one, they didn't perform any embryo transfer. They measure the progesterone levels between day 0 and 8, and also they evaluated the characteristics of the recipients to see if they will be suitable to receive an embryo or not on day 6. So they had three groups. First one received salina to induction of ovulation. The second one received a dose of HCG to induction of ovulation, and the third one received a dose of HCG 1 day after the ovulation, on day 1. So in the progesterone levels, they saw that both the treated groups between day 4 and 6 had a higher progesterone levels when compared with the control group. And as I mentioned, they looked to these recipients, evaluated them with ultrasonography and also just with the transrectal palpation. And more mares from the treated groups were suitable to receive an embryo on day 6 when compared with the control group. In this other study here, they didn't perform any embryo transfer, but they inseminate all these mares and they give the HCG. For the group 2, a single dose of HCG on day 5 after ovulation, and then to the group 3, a second dose of HCG on day 11. And they measure the progesterone levels, and they saw that the mares that had a secondary luteal tissue, they had an increase in the progesterone levels, similar to those ones that had double spontaneous ovulation. However, they didn't see any changes in the blood flow in the ovary and neither in the uterus. And then also they didn't see any difference between the pregnancy rates of the mares. In the control group, 50% of pregnancies. In the group 2 that received only 1 dose of HCG on day 5, 45% of pregnancy. And the mares that received a second dose of HCG on day 11, only 36% of pregnancy. So it's not clear if HCG can increase the pregnancies, because we have very different results, but it's shown that it can increase the progesterone levels due to the development of the secondary luteal tissue. And now let's talk about our beloved acyclic recipients. Again, some published results. Here, different number of embryo transfer since 55% of pregnancies until 90% of pregnancy using acyclic recipients. We have different protocols using different sources of estradiol, different sources of progesterone, and the combination between them. And let's take a look into some of these protocols. In the first one, no source of estradiol, only progesterone oral 1, achieving 55% of pregnancy with 30% of pregnancy loss. In the second one, using cipiolato estradiol, 2 days in sequence, short and long-acting progesterone were 2 groups, and the average of the pregnancies was almost 76%, and 22% of pregnancy losses. In the third one, estradiol benzoate, 2 days in sequence, long-acting progesterone achieving 76% of pregnancy with 10% of the pregnancy loss. The fourth one, 17-beta estradiol, 3 days in sequence with intravaginal progesterone release device, 72% of pregnancies and 12% of pregnancy losses. And in the last one, using clomiphene citrate, 4 days in sequence, short-acting progesterone achieving 91% of pregnancy and 90% of pregnancy loss. So we have a lot of different protocols nowadays, achieving different number of pregnancies. And what are the tricky points to increase the pregnancies in the mares? It seems to be the length of the estradiol phase. Here in this paper, they had 3 different groups. First one, the long estrus, the mares received estradiol benzoate for 5 days. 72 hours later, they receive a dose of long-acting progesterone. The second group, short estrus, 1 shot of estradiol benzoate, and 48 hours later, progesterone long-acting. And the no estrus, only progesterone. All these recipients receive an embryo on day 4, and on day 6, a uterine lavage of these recipients were performed, trying to recover this embryo and checking to see what are the difference between them. And what they saw, both treated groups with estradiol, the embryos had an increase in the size higher than the no estrus embryos. Here is the size of the embryos on day 8 when they were flushed, and here the size of the embryos on day 10 when they were recovered from the recipient. Also, the likelihood of a recovered embryo for this recipient were higher in the long estrus, recovering 85% of these embryos, then compared with the short estrus, 62%, and the mares with no estrus, only 46% of these embryos were recovered from the recipients. This, in this other abstract, they use a 17-beta estradiol with intravaginal progesterone release device, and they find similar results. 3 days of estradiol had a lower pregnancy rate when compared with 4 days of treatment. This is not only for acyclic recipients, it's also true for the cyclic recipients. In this study, they searched for the factors that were influencing the pregnancies in the recipient. And what they found, the donor age, influencing the pregnancy in the recipients, the operator's skills, the number of DCLs on the day of the embryo transfer, and also the days of the endometrial edema. So here, the mares that had more than 3 days of estradiol phase, a good edema in their classification here, so 82% of the recipients become pregnant. Oops. When the mares had less than 3 days of a good edema, only 63% of them become pregnant. And when they show 0 days of a good edema, that mares that had only a slightly increase in the edema in their scale, 50% of them only got pregnant. So they show that as long as the days of the endometrial edema, as higher as the pregnancy rate in the cyclic recipients. And here, what are the patterns and characteristics that we want in these recipients? Eventually, we will see some edema in the acyclic recipients. It's normal. Of course, we don't want any fluid, and we want a good uterine tonus. A good tonus for acyclic.
It's working?
No. He was already expecting that. Okay, back. Oh. Alright, no. Okay, let me finish. No? It's almost done.
Hello? Hello? Hello, it's working? Yes.
Okay. Alright. So we also want a good uterine tonus here, but the tonus of a cyclic recipient will never be the same. It's working. Okay, straight. It will never be the same as a uterine tonus of a cyclic recipient. So if you have 2 recipients on day 5, the uterine tonus of a cyclic recipient, it will be lower than a cyclic recipient. And how I do my protocol at MK Arabians, I like to use the mares between day 4 and 6, but mainly on day 4. I use estradiol benzoate and progesterone longer acting to protocol these recipients. So here we have the donor timeline with the flush on day 8. And I start my protocol in the recipients on the same day or 1 day before the ovulation of the donor mare. Then 24 hours later, I will check this recipient to see the DIMI score. And 24 hours after checking or 48 hours after the first shot, I will give my second shot of estradiol benzoate. And here the dose it's different because depending on what I see in the ultrasound, I will adjust my dose. So if I see a huge edema, I will decrease the dose a little bit. And if the edema is too low, I will increase the dose a little bit as well. And if I have enough time, I will wait 48 hours to give a shot of progesterone longer acting. And if I don't have enough time to work with this recipient, I will wait only 24 hours and I will give the full dose of progesterone longer acting. Then this will give to me a recipient around day 4 or 5 on the day of the flush. And if I have an embryo, I will give a full dose of progesterone long acting again. Now I will share with you the results that we had in the farm in these 3 breeding seasons. Using acyclic recipients, we performed 16 embryo transfer and we achieved 93% of pregnancy rate in these recipients. Using cyclic recipients only that didn't receive any kind of treatment, 21, and we achieved 90% of pregnancies. And using cyclic recipients that receive extra support of hormones or antibiotic, anti-inflammatory, or the combination between them, we achieved 72.5% of pregnancies. And this, if you think about it, it's kind of logical, because if I am giving something extra, it's because something went wrong. or my procedure were not well done, I take too long to finalize the procedure, I have some difficulties to go through the cervix, or something happened with this recipient, maybe she had fluid a few days before, or during the estrus phase something happened. So if something went wrong and I have to give extra support, the results will not be so good as could be. And what are the take-home message of this talk? That the length of the endometrial edema is important for both cyclically and acyclic recipients. That we have different protocols that can result in pregnancies, different sources of estradiol, progesterone, and the combination between them. However, are we doing the best protocol? Are we choosing the best protocol to achieve a better result? Because today it's not possible to us to do the things by guessing anymore. We cannot choose the protocol blindly and hope for the best. The pressure on us to achieve a very good number of pregnancies with a low number of recipients is too high. So we must find the information available that we have, explore what can be, explore what are available to us to get our protocols adjusted, trying to achieve the best results that we can.